So yesterday we saw a few things about breast cancer. So today I'll continue. So the lobular cancer. Again, lobular cancer, among the invasive cancers, most common cancer is ductal in origin, ductal cancer. So what we call as infiltrating ductal or invasive ductal cancer is the most common cancer, 90% of them. And within that, we have specifics like the most common group within that 90% is the infiltrating duct carcinoma, not otherwise specified, the general category. And then you have specified categories like the medullary mucinous and tubular, metaplastic, and those varieties. So in the total, 10% of it is due to the what we call as lobular cancer. Now, it's important to understand lobular cancer in order to be able to detect it early. So this lobular cancer has some peculiar features. They are quite often said to be multifocal and bilateral. So the bilaterality is supposed to be as high as 20 to 30%. And it is the hardest to detect on mammogram, and quite often presents late because it's difficult to detect clinically, it's difficult to detect radiologically, and it's also difficult to for the patient also. But by the time it becomes a significant symptom, it is far too advanced, and it's very difficult to pick up on a routine screening mammogram also. I'll show you some images. That's why it's like it's radiologists are often like, you know, they are so scared about missing a lobular cancer. It is a nightmare. And so why is this so difficult to detect? Because these things grow in a single file. So if you look at the pathologist description, he'll say in pathology lessons you would have read something about Indian file pattern. So because it goes in that single file, it may not be, it doesn't form a mass, and it innocuously keeps going in single files, and then by the time it forms a mass, it becomes quite late. And lobular cancers you don't find, because they keep growing insidiously, they don't cause any major necrosis, and so therefore there is no microcalcification. Sometimes, you know, normally in a mass lesion, any finding in the breast because of a pathology, you expect it to be found on both orthogonal views, isn't it? You say you take orthogonal views in the breast is your craniocaudal view and the mediolateral oblique view. So it should generally be present in both the views. But peculiarly, lobular cancer is usually seen in, sometimes, you know, seen only in one view. Other view may not show. So if you see it only on one view and the other view looks normal, don't dismiss it. You know, just think again, look for subtle signs and keep the level of suspicion higher. And again, in the early stages, there's only very subtle disturbances and you don't see much at all on mammogram. And similarly with ultrasound also. And also with MRI. All three modalities have some disadvantages in picking up lobular cancer. So it is a challenge, and it is a radiologist's nightmare. So see, this is the pathology. If you see these blue dots that you see, they're all in a single line, isn't it? It's like, you know, one after the other, one after the other, one after the other. It is not actually causing like a chaotic mass. Because if it grows like that, it forms a mass, and the mass is easy to palpate. Whereas if it grows in a single file, it can do a lot of growth before it becomes apparent. So this, there are also very little host reaction. So there no mass formation, no fibrosis, no spicule formation until very late. And like I said, it doesn't undergo necrosis because the cells have to grow, heap up on themselves, deprive blood supply for it to undergo necrosis, and followed by calcification. Here it doesn't happen because it goes one after the other. So that is why there is not much calcification also seen with this mammogram. Now, why is this called Indian file pattern? So this is a little bit of a story. So in the olden days, when America was occupied by its original inhabitants, and so these people are called Red Indians, isn't it? So these native people, they would ambush the settlers. The settlers are people who moved from Europe into America, and they tried to take the lands and cultivate and do whatever they wanted to do there. But then the again hostility, isn't it, to the native people versus the settlers. So this settlers live in camps, and these native people would actually ambush them, and they have a very deceptive way of doing it. What they do is each one walks into the other's footstep. So when somebody actually looks at a track, you don't find chaotically many boots, many footprints. You only see that one footprint. So one might end up thinking, oh, there's only one fellow, and that one fellow I can tackle. And if you actually then you look at it, there'll be like teeming with like hundreds of people ambushing the settlers. So this is why, because they come very stealthily, and they come in a single file very deceptively to think that there's only one person, but it ends up being so many. So which is why it is also very difficult to pick up on mammogram. And even in pathology, that is why they ask for special stains for leak adherin. And so if sometimes it is challenging even on pathology in the early stages, particularly with the lymph node, and you do an FNAC of the lymph node, or you do a sentinel lymph node biopsy with frozen section, sometimes it's very challenging for them to most of the false negatives with lymph nodes on frozen section is because of lobular cancer. So if you do a lobular cancer and send a sentinel node, and they tell it's negative, you should be wary about it, because it's again very difficult to perceive metastatic spread on the node on frozen section, and the false negatives can be there. So the pathologist should be alerted to the original pathology on TrueCut. So this is the reason why it is called Indian file pattern. So if you look at what happens, I have about 6 or 7 images. I'll show all of them. So what happens is, as it grows in single file, and it kind of spreads its footprint all around the breast, and it gently contracts the whole breast, and the breast shrinks. And if a woman comes and tells you, over a period of time, my one breast alone is becoming slightly smaller, slightly firmer, and you don't feel any distinct mass, she doesn't feel any distinct mass, remember, it could be lobular cancer. So if you look at this, between the right side and left side, look at the left side. Left CC, the breast tissue spread widely all around. You can see the breast tissue spanning the entire breast. This is a pre-mammary area. This is the mammary zone. This is the retromammary area. Look at what's happening. So this is actually, this whole bit is tumor. And what it has done, it's grown and then it starts sort of, it pulls itself into and the whole thing has shrunken. So all of this breast tissue, it's grown, and then the whole thing is shrunken here, and this is actually tethering and involving the nipple areolar complex also. If you can see, there is some thickening of the nipple areolar complex. Look at the nipple areolar complex on this side and look at it on this side. So it's quite easy. Sometimes I see people missing it even with something as stark as this, because causative gland, this can be made out, but this actually, it looks more or less symmetrical, and if you didn't pay attention to this, you might just call it off as normal, and then you end up missing this. So this is a classical sign on ultrasound. So if it grows and forms a significant amount of lesion, then what happens, see, the Cooper's ligament actually comes and reaches the top. And these things grow into that Cooper's ligament like that, and actually peaks up like snow peaks. And if you look at this is actually called Tom Stavros. He calls it that a twin tower sign, or the Tower Bridge sign. And if you've seen the Tower Bridge in London, you see those two little pillars there. So like that, so it just peaks like that. You you find some distortion is happening here. Here there is definite hypoechogenicity, but sometimes you don't get a clear mass. It's just, but you see something protruding like pillars, like little peaks. So this kind of peaking is classical of lobular cancer. When you see something like this and it's reproducible, you scan and then go back to another area, come back and scan this area again, and it keeps on coming back to you with this kind of peaking appearance. Don't miss it. This could be a lobular cancer. So again, in this mammogram, it could easily be dismissed off as okay, dense breast and nothing further done. And then the ultrasound also may not show much. If there are a bit more axillary nodes here and seen on the other side also, so you may not, particularly Indian women, they do a lot of hands-on thing, and you have all these little infections in the nails and whatever, and they may have quite a lot of nodes, and you might actually dismiss them as reactive nodes. But if you carefully see, if you see, this is the pre-mammary zone, this whole area is the mammary zone, and this is the retromammary area. And follow the line. There should not be any pulling, tethering. And if you see this side, there's that smooth area. There is nothing tethering, pulling, pushing. Whereas if you follow this line, what happens? It is actually, this is what we call as a tent sign. It's tenting. So something is pulling it from here, and you actually don't see a distinctive mass here, but there's something obviously pulling. So these are the situations where actually doing a tomo will help. In a particular slice, actually you may actually see something there. And if you see the CC again, there's not much retromammary area to be seen here. Maybe we should pull it a little bit more. But here, if you see, there is something a little bit more dense than the other side. Very subtle. One could easily miss it. This ended up being a lobular carcinoma. Again, look at the ultrasound. So there's one little peak here. There's another little peak. And this actually shows some hypoechogenicity. Again, in passing, if you don't look for it, you may actually just do it and miss it. So these, again, when you have an index of suspicion in that mammogram, focus more in that particular area on ultrasound. Invariably, you will see a finding. So this, again, this patient, somewhere outside, she had a mammogram, and this was given as normal, except for this. In the fibroadenoma class, we learned about how it degenerates, involutes, and become these chunky calcifications, what we call as popcorn-like or coral-like, whatever name we care to give. So these were reported. They had mentioned this and given a BIRATS 2 or something. So the patient just brought to me concerned about these chunky little calcifications, because when you write calcifications there, patient goes and they go Google, and when calcifications, Google will show up cancer. So because of that, she came to me, and when we saw, obviously I was not very happy with this distortion here. So there is something like some convergence here, like a star stellate like appearance. So obviously I didn't want to ignore this, and this was seen only in one view. If you look at the other view, there's nothing much seen. Here I was a little uncomfortable here. So we use a tomo. So in the tomo, if you see on this side, this is the area that I was not comfortable with. This is a tomo video. Can you actually see this image from here to here? Can you actually see the distortion becoming more apparent?
Yeah, yes, we can.
It's quite subtle. It's not easy. It's very subtle. But anything stellate, anything converging, straight lines converging to a center or to a corner, have a suspicion. So something is causing that reaction, and therefore one should look at it. For this is again very subtle. There's nothing felt clinically except for those chunky calcifications. A slim lady, old lady. She was 70 plus. And this we biopsied, and I will show you. And incidentally, on the MLO, let me go to the previous image. On the MLO, again, this area I was not happy with. There was some little distortion. So again, CC didn't show much actually. I'll show you the video of the CC. So it is the tomo images, it sweeps the entire breast and you see every section. So this didn't show anything. Let me go to the MLO. So again in MLO here, so can you see that, like there is again some star-like appearance that is emerging. So it is in that slice. Yeah, can you see that now? That slice. Let me. That slice there. So just pause it, and if you see that area there, there's like a star-like appearance. So so ultrasound is very, very subtle. Actually, this is the left.
Selvi, I have a request. Can you put the light on in your room because it's all dark behind you?
Oh, okay. Is it better? Is it better?
Yeah, certainly better. Yes.
Yeah. So, do you want me to go back to that previous one, or is it all right?
You can go back and. Yeah, sure.
So this area, if you see, you can see it emerging. So that star-like appearance is what we call as architectural distortion. And so normally we don't want, see that stellate little appearance is something what we call as architectural distortion on mammogram, very subtle. And remember, this lady had no symptoms. She just had a routine mast-cell checkup. They had a mammogram, and that mammogram was reported normal by BI-RADS2, and they mentioned calcifications, for which she was alarmed and she came to me. And ultrasound did not show anything significant. The left side, just a little small, little subtle peak and something slightly hypoechoic there. No definite mass for me to feel except those calcification, a bit of shadowing, but what is faintly seen here is that little peak. And that another view. Sorry, just. So this turned out to be, I did a biopsy of this, and for the right side ultrasound was completely normal, and then even this subtle peak was not there. So left I biopsied here, it was invasive lobular cancer. On the right, I did a stereotactic biopsy, and it was lobular cancer. I did a bilateral mastectomy and sentinel lymph node biopsy. Both sides sentinel lymph node biopsies were negative, and further subsequent H&Es also were negative. But can you believe it? On the right side, where it was so subtle, it was a 3.5 centimeter invasive breast cancer. And on the left, it was smaller actually, 2 or 2.5 centimeter invasive breast cancer. So this is how it can be deceptive. And if we had missed it at this point, next year she'll come back with a shrunken breast with significant nodes and a much higher stage, maybe something like stage 3, and where the outcomes are going to be much worse. So this is very important. So this, I think I already showed you. And this is how it looks on ultrasound, and nodes we'll discuss separately. So this was another lady. Look at it. She had a mass. This is much advanced. So look, I wanted to show how it shrinks, and see, this is a right breast, and you can see the contour of the breast. This is the breast fat. So you can see the difference. There is a little subtle difference between the breast fat and the fat above the premammary fascia. So what is that premammary fascia? It's a deep fascia splitting, and then the breast tissue grows within, and this is that superficial layer of that deep fascia, and above which is the subcutaneous fat. Between this fat and this fat, you see that difference, and you have that normal contour of the breast. This was the original size of the breast. Look at what happened here. So this is actually much advanced. Now this is actually formed a mass. Look at what it's done. It's shrunken. It's grown insidiously, grown all over the breast, and what it's done is it's pulled towards one side. And this is what lobular cancer does. And look at what is happening here. This is a large, significant axillary lymph node, and all of this is shrunken to form this big mass. You can see that this is a normal nipple areola here, and here you see that thickening of the nipple areola. And that is ultrasonologically again very deceptive, and that actually doesn't show much of a mass, just two little peaks here, and some shadowing, but very deceptive again, and it doesn't correlate. What you see on mammogram doesn't correlate as much as with ultrasound. And look at the lymph node here. I'll discuss lymph nodes later, but to suffice here to tell that it is a very abnormal looking metastatic lymph node. So again here to show that these are all slightly advanced lobular cancer, slightly actually advanced lobular cancer. Just wanted to impress upon you how it shrinks. Again, look at the way the breast tissue is distributed here and what is happening here. It's all kind of shrunken to one corner. So this is classical. Again, I told you about that one view bit. If you look at this, here you can see that it is shrunken, but generally otherwise, like, you know, cursorily if you look and if somebody only shows you that, you might actually miss it. And if you didn't have that radiological eye, you might actually miss it. So this again, so it's more prominent in one view than the other view. And this is how it looks on ultrasound. So much happening there, but not much shown on ultrasound. So it can, again, here, if you look at this view, this is again it is all kind of shrinking towards the center. With there's this architectural distortion is well perceived here, isn't it? It's like pulling towards, and it's not like normal breast tissue, which is quite harmoniously arranged. Here it's all pulling, and it's actually involving the nipple areola complex. So on the MLO view, again, you can actually see this entire breast size itself is shrunken. If you look at this size MLO view, the breast itself, what happens over a period? The breast itself shrinks. And see what's happening there. And this, again, ultrasound shows some peaks like that. So when you see those little tower-like things, like you know, pine trees growing up, think of lobular cancer. This was more a classical presentation of a spiculated mass. This no one will miss. And so this actually is the mass, and you can actually see that extension going up there. So all this will be tumor. So if you just end up removing this, she'll have a recurrence. So this is how it is on. And this one again, look at this. This is again, apart from that slightly increased density and a little bit of more cluttering, you might actually, and the contrast is slightly different. Other than that, you don't see much. And here also, and look at that shrinking. You can, between this and this, there's not much perceived. You can see that little bit of shrinking, but it is more visible on the CC view. Look at the breast size here and look at what's happening here. So this is what lobular cancer does. Again, you see ultrasound. I'm showing a lot of these images because these are all very, very, it's not very common. It like I said, it's only 10%. Majority of them are ductal, but these come late because we fail to pick up. One, it's difficult on our part to pick up, and it's also difficult for the patient to, because by the time they form a mass or a heaviness or become symptomatic, it's already too late. And we should be aware of these findings. So when you actually see them, you'll be able to pick them up early, which is why I showed you a lot of images on that same topic. So we'll move on to lymph nodal assessment. We all know that assessment of lymph nodes is an integral part of breast cancer management. And why? Because one, you clear, there is disease there and you clear. Disease control is important. Two, it also provides prognostic information. So obviously more number of nodes involved, what are the prognosis? And then also it provides information based on which you decide adjuvant therapy. I mean, these days we use other prognostic tests like Oncotype DX, Mama Print, whatever not. But but still, conventional histopathological assessment with proper lymph nodal assessment is important, based on which you prognosticate, you control the disease, and also you make adjuvant treatment decisions. So it's important to understand the lymphatic drainage of the breast. We all know all these anatomical terms: prepectoral, pectoral, retro interpectoral level 3 nodes, all that we know. So the pectoralis minor divides the axillary triangle. So anything that is lateral to the pectoralis minor, behind the pectoralis minor, and then medial to the pectoralis minor. So this is how you divide the levels of axilla. And a classical modified radical mastectomy would involve removing all 3 levels of axillary lymph nodes, and it actually, that is the only thing that makes this surgery challenging. Otherwise, like, you know, subcutaneous pain, removing the breast tissue is hardly a surgical challenge. So how does the breast drain into the axillary lymph node? So if you go back to your McGregor days, you read about this subareolar plexus of Sappi. So what it does is all the breast tissue, including the skin of the over the breast tissue, the lymphatics converge to the central plexus called the plexus of Sappi in the subareolar region. And from there, a few chains reach the axillary lymph nodes. So they 1 or 2 chains, or sometimes, you know, they all join together to form 1 or 2 chains. So these chains land up into the first echelon of lymph nodes. So, and then from there, you know, lymph nodes, you know, there is an afferent lymphatic and there is an efferent lymphatic. So lymph fluid comes in, and then lymph fluid from that lymph node goes to another lymph node. It acts like, you know, you can, you know, like junctions from which like lymph fluid travels to complete the circulation. So the first echelon of lymph nodes, it may be 1, it may be 2, usually it may be 1 or 2 chains, so you end up finding more than 1 node, definitely. Sometimes you find only 1 node, but generally 2 to 3 nodes definitely you will find. So these are the first echelon of lymph nodes, and the funda behind the sentinel lymph node biopsy is, if these first set of lymph nodes are negative, then the others are bound to be negative. So the reason why we are also worked up about axillary clearance is that you are permanently disabling that woman and putting her at the risk of developing a lymphedema. So lymphedema is a serious risk, right? Because, you know, with all the treatments, we are improving her quantity of life, and she's going to live longer, and you don't want to condemn her to a life with a swollen arm with a lymphedema, which is very, very crippling, and which is why this whole concept of sentinel lymph node biopsy came about. So if the first echelon of lymph nodes are negative, then you can, with reasonable certainty, assume that the rest of the lymph nodes are negative. There can be skip metastasis. It can happen. So there can be skip lesions, and sometimes what we call as false positives and false negatives with sentinel lymph node biopsy can happen. But now this is a well-validated technique, so one has to undergo training, particularly in identifying these lymph nodes. So earlier on, about 10 or 15 years ago, so this concept came about in the 90s, and early 2000, most parts of the world have adopted it, and most of the units initially, when they adopted it, they validated. So say a set number of patients, either 30 or 40 patients, would undergo both. They'll take out the central lymph node, get the frozen section, and also meanwhile clear, and then you'll know your false negative rates and false positive rates by doing this technique, validating oneself. And then if your pathologist is happy, you're happy with the results, and the false negatives are low, then you go and offer it as a standard of care. So this is what we all did when we trained, because we trained initially when we started doing breast surgery, it was all axillary clearance, and then that was what we practiced in the 90s, and then early 2000 also, and then somewhere in around 2004-5, England adopted it as a standard of care by validating. So the Royal College actually trained a few people, and then these few people were allocated to train other people. And by now, if a person without proper reason undergoes an axillary clearance, they can be sued actually. So now sentinel lymph node biopsy is the standard of care Obviously, if assessment of the lymph node becomes important, so who should undergo sentinel lymph node biopsy? Which is why now we have to understand how it looks on imaging. And more than mammogram, ultrasound is useful to assess lymph nodes. So we all know lymph nodes are uniform in structure, kidney-like structure, and a lymph node has a cortex and a medulla. So the medulla is where the hilum is where the lymphatics and the blood vessels come to, and then that is the medulla, and then the cortex. So the cortex is usually hypoechoic. Hypoechoic, like I said earlier in the previous classes, usually means darker. And the medulla is usually fatty, and fat is bright, isn't it? Fat, the echogenicity of the fat, we keep it sort of medium gray, it is brighter than the cortex. So the normal lymph node, particularly in older women, is more fatty than and the cortex is very, very thin. And this is how it normally looks. The cortex is usually uniform, and if you see, that is uniformly there, and it is usually no more than 2 to 3 millimeters, and the entire middle of the node is the fatty hilum. And if you, this node, this is also a node, you see that thin rim of hypoechogenicity, just to mark that distinction between the fat and this. This node is almost entirely replaced by fatty changes. The entire medulla is replaced by medulla with all fatty changes. This is an elderly woman whose node looks like this. And this is hyperechoic medulla and the very thin cortex. So if you see something like this, these nodes need to be biopsied or sampled. And this is how the hilar blood vessels look. So if you see, this is again the uniform node, and it is actually, the cortex is uniform, is slightly thicker than usual. So if you have a reactive lymph node, so if patient has had a surgery there or some infection in the hand, you have reactive lymphadenitis, isn't it? So the reactive lymphadenitis looks something like this, where the cortex is thickened more than 2 millimeters, but definitely thickened, but uniform. There is no sharp edges, there's no bulges either this way or that way. And this cortex, both the outer layer and the inner layer, both are uniform. And you see that fatty medulla, into which you see blood vessel. This is a normal blood vessel that goes into the hilum. So in a patient who is clinically you don't feel any nodes, and you do ultrasound, the nodes look innocent. So these are the patients who should have sentinel lymph node biopsy. If they are obviously metastatic, then they should be planned for axillary clearance. So earlier we would selectively biopsy these nodes, FNAC and core biopsy. Now, even if they are obviously metastatic, we still put a needle into it and biopsy, because particularly in our country, we have a lot of tuberculous nodes, and they also look metastatic, and then we end up clearing all of them unnecessarily. And it's worth actually biopsying it. One, it provides better staging. Two, again, if it is granulomatous, then we don't have to sacrifice all the nodes. And so therefore, even if it is obviously metastatic, we on ultrasound, we now actually do a sampling of the node. So this is the dye. There's a lot of debate about, should we give the blue dye or the radioisotope, peritumoral, intratumoral, subdermal or subareolar. Now, if you know the anatomy, all the lymphatics drain into the subareolar plexus of Sapi. So if they're all going to converge in the subareolar plexus of Sapi, then it suffices if you give your blue dye or radioactive isotope in that subareolar region, and it will reach the sentinel node. You don't have to poke around the tumor, inside the tumor or around the tumor and disturb that area. And so therefore, give it in the subareolar region. So what do we use? So the Westerners use patent blue. Patent blue is a food dye in our country. It is not available for medical use in our country, and we have to import it, and it becomes very expensive when you import it. So what we use is methylene blue. So methylene blue is available in 5 ml ampules or 10 ml ampules. Hardly costs anything, 50 rupees or something. And if you open one vial and you can use it for 2-3 patients on the same day, you obviously don't carry it over to the next day, but it's that cheap. So, and only thing is with methylene blue, don't inject into the skin. Intradermal injection, you can actually cause skin necrosis. I have had that issue. And it also sometimes, you know, some people use methylene blue out of those bottles that you have, which you use for the fistula and earlier on, people used to keep it in bottles, autoclave it, and it keeps coming back and, you know, going back and forth. And if you use that methylene blue, then there is also a risk of serious inflammation, and it can cause quite a lot of inflammation, and, you know, patients form tissue necrosis in that area, and it confuses at a later date with various things. So, which is why, you know, sub-areola, make sure that it's proper sterile out of an ampule, sterile ampule, and give it just before you go and scrub, and the patient is induced, after inducing. So this is blue dye. So radioisotope, when do you inject? Radioisotope, obviously you need a ARB license. Only nuclear medicine people can inject. So the patient can go, suppose you operate in the afternoon, you can send her in the morning for the injection. Suppose you're doing it very early in the morning at 8 o'clock. Then you can get it injected the previous evening. So the half-life, usually it starts declining, and the radioactivity starts going down. And then if it is more than, so say 12 hours, so you have to make sure that you, if they give the previous day, they may actually increase the dose. Instead of 20 MBQ, they may give a little bit more. So you have to instruct the nuclear medicine people as to when you're going to operate as well. Or if you're operating like 10 or 11 o'clock, then you can send them first thing in the morning and get injected, if you're using a dual technique. So it can be done with only a single technique, although it's advisable, particularly in the learning curve, to use a dual technique in order not to miss a sentinel lymph node. So this is how it looks. It looks as blue as that. It's very difficult to miss it. It's sitting right there. You know, normally all of us will have a natural crease in the axilla. You don't have to go high up at all. People make the mistake of incising, say this is the armpit. This is where you need to place the incision. People go very, very close to that axillary crease. That is a very uncomfortable place for the patient as well as for you to operate. The lowermost crease, natural crease that a patient forms, that is usually where the axillary sentinel lymph node biopsy is there. Make an incision, maybe about 2.5 centimeters, and you can put a retractor comfortably inside, and, you know, just get into that clavipectoral fascia, open it, and then the lymph node is just sitting right there. And sometimes you can actually trace it with the lymphatic channel, and it's very difficult to miss. Now, if you use a radioactive probe, it's quite easy to look for radioactivity and pick up other nodes. With blue nodes, you may have to do a little bit of dissection, which can be a little sort of untargeted. But it's with practice, you know where to look for, and you'll almost always find it. So pick up this lymph node. Again, be careful not to crush it. Again, if you put an Ali forceps or whatever that you want to hold, make sure that you don't crush the node. Hold it below the node, and then don't take too much of fat along with the lymph node. The pathologists don't like it, and pick up only the node. And also, the purpose of doing sentinel lymph node biopsy will be lost if you remove too much of tissue there. You'll be disturbing the lymphatics. So just pick the lymph node alone and then send it to the pathologist. And most in our country, we are fortunate. Most places where we have frozen section facility, and they tell you whether it is positive or negative within about half an hour. So if so why is it called sentinel lymph node? Sentinel means a guard. So the first echelon of lymph nodes are the sentinel nodes. So these are the nodes that are the guarding gates for the rest of the axilla. If these nodes in the gate is negative, then the rest are negative. So the false negative rate should be less than 5%, and the accuracy generally is over 95%. So what do the nodes, metastatic nodes, look like? So remember earlier I said about cortex. Cortex is usually only about 2 millimeters, and it is uniform kidney bean shaped with the central medulla. See what has happened here? This is all cortex, and it is not uniform, obviously. It is bulging here. And then the medulla is displaced. There's hardly any medulla. It is actually pushed to one corner. Here again, it's pushed to one slit, and it is thickened in an ununiform fashion. So it is bulging here. And if you say here, it is uniform, but these sort of bulges, looking, this is the fatty medulla, but kind of bulge into that medulla is not good. So although it looks deceptively uniform, if it kind of bulges into the medulla, either this way or that way, then it is an abnormal node. So here again, if you see, the medulla is pushed to one corner. So it's like what we call as the Mickey Mouse, Minnie Mouse type hat-like appearance, and rat bite, as if a rat goes and bites into cheese. It's two teeth alone plunges it, and it leaves behind a mark. So something like that. This is that.
We have 10 more minutes.
Okay. So this is that Mickey Mouse type hat, and you see that bulge here, and so some more here. See that bulge into the node, and see how slit-like the medulla has become. And this here, the medulla is entirely replaced. And if you look here, this is a node that has perinodal infiltration. So the node itself is jagged and it's coming out into the fat. So these are some mammographic appearance, and sometimes you find calcifications within the node also, which is seen here. And the vascularity. So normally I said lymph nodes, the blood supply into the lymph node comes from the hilar region. Here, the hilar region, there is some flow here, but what happens here, look, it's there in the capsule also, which means the growing metastatic cells makes its own blood vessels, neoangiogenesis here. And if you see peripheral blood flow in a node like that, that's usually metastatic. So I think I should leave margins for another day, and because that is another topic by itself, I'll combine it with something else. So any questions at this point?
Hello. If
Yes.
someone operates for the don't operate for sentinel lymph node biopsy in periphery where it is not available,
Yeah.
then is it a medical legal issue?
No, you can do the Tata technique. So Tata, what they do is below you identify the intercostobrachial nerve, and below that do the axillary sampling. So that actually we will end up taking more than 4 to 5 lymph nodes. And if those nodes are negative, you can safely assume that the rest of the axilla is free. So what you mean is, if you don't have blue dye, everybody will be able to get. If you don't have frozen section, is that what you meant?
Yeah.
So frozen section, it is a challenge, because if you end up having a positive lymph node, then you going back for a second surgery after you get the pathology is a challenge. But then there's an issue here now. See, I don't know how many of you would have read the Z11 Amaros trials. Now the patients who undergo breast conservation, if sentinel lymph node is positive, we actually do not go back and clear the axilla. We're going to radiate that breast because she's had breast conservation, and in that radiation we include the axilla also. So that is what Amaros trial is all about, and that is equivalent to you having done an axillary clearance. This applies only for patients who undergo breast conservation. Now this indication is now being extended to mastectomy also, but all of these things are fairly new concepts within the last 6 or 7 years, and it's not percolated well into our country, and because we see a lot of patients with far more advanced disease, and at an undergraduate level or even as postgraduate level, your teachers, people who examine you are not going to actually accept those answers. Whereas a surgical oncology PG might be expected to know, but these are things that, a lot of debates are going on. Let me tell you what I do in practice. So if I obviously assess carefully on ultrasound, I biopsy the lymph node, and if it's obviously metastatic, then the patient goes either upfront surgery or if they have neoadjuvant chemotherapy, then there is a concept of doing sentinel lymph node biopsy after neoadjuvant chemotherapy. So these are all very select situations, and we carefully assess before we actually do that sort of a planning. And it's also multidisciplinary. So I discuss with my radiation oncologist, talk to my medical oncologist. So all of this happens, and then we take a call together. Now, if it is a upfront surgery and I do a breast conservation procedure and do a sentinel lymph node biopsy, and if it is 1 node out of 3 that are positive, and the patient it's not a triple negative disease, and it's not it's like a grade 1 or a 2 tumor, then I might not do an axillary clearance. I will just radiate the breast and include the axilla into the radiation field. But these are all like, very carefully followed up and carefully assessed patients. And I wouldn't want to, I don't know, see, this is a very mixed crowd. I don't know how many are surgical oncology people here and how many are general surgical people. So I would not want to confuse further. I would say if this clinically node negative, radiologically benign looking nodes, those are the patients that undergo sentinel lymph node biopsy. Now, if you do not have frozen section facility, you can still inject blue dye. You don't need to use radioactive isotope. Just use blue dye. The nodes, you will pick up the nodes will pick up the blue dye. Now harvest those nodes. In addition, take the level 1 below the intercostal brachial level. Go and read the Tata paper. They will describe the technique about how to do this sampling. So you take that out, and if you have frozen section, well and good. If you don't have, then if these are negative, then nothing further needs to be done. If this is positive, then there are 2 options: take the patient back for axillary clearance, or if the patient has radiotherapy, include the axilla and the radiotherapy. So, but I know I do not teach in medical colleges, and I don't have a clue about what the examiners expect. But these are things like, you have to be wary about saying, you don't know who's coming as an examiner. So be careful about these things.
Yeah, next question. Anyone?
Ma'am.
Yes.
Excuse me, ma'am.
Yeah.
Yeah, ma'am. Am I audible, ma'am?
Yes, I can.
Yeah, ma'am. If you're contemplating a breast conservation surgery in a case of ductal carcinoma in situ,
Yeah.
The actual management depending upon the Van Nose index.
Yeah.
Most of the components of it being determined after the biopsy. How would you determine the best possible treatment for the patient pre-operative?
So that is where actually mammographic assessment will help, and that is going to be the next session that I cover. How do you assess the extent of the lesion, and which patients do you decide to conserve, and which patients do you decide to offer mastectomy? So that is something mammographically and ultrasound wise assessed. And then if you're convinced that, not all calcifications are extensive, so quite a few are localized to a small cluster, and these people, and you can just remove that cluster, and then depending on the size of it, grade of it, and all those various things that I showed yesterday, you decide for the need for radiotherapy. So if the score Van Nuys index is less than say 6, then you can omit radiotherapy. Or if the patient has a lot of money, then you ask for an Oncotype DX test, which determines the level of risk of recurrence, and then based on that decide for radiotherapy. So these are all possible, but that requires careful mammographic and ultrasound assessment that I will show you some other time.
Thank you so much.
Sir, good afternoon. Oh, good evening. Santosh sir is here. How are you, sir? Oh, I can't hear you. You're muted. I can't hear you.
Can I ask another question? Methylene blue should be injected in the subcutaneous area, in the periareolar or subareolar?
Subareolar, yes.
In subcutaneous area, subcutaneous plane?
Just under the skin.
Just under the skin.
Into the skin, it will cause skin necrosis. Just under the skin.
Okay, thank you.
Like a subcutaneous injection.
And which trial you told just now? Which trial you told?
One of the first trials was what we call as this Z11 trial. And if you just Google ACOSOG, ACOSCOG, Z11, that was one of the first American trials. Now, based on this trial, the Americans changed practice, but this trial has a lot of caveats, and not many are happy with that trial. So, but the British will not accept what the Americans do. No, so they did their own trial. And Almanac was the first trial which looked at the safety of sentinel lymph node biopsy, and then they had the Amaros trial, which looked at if you have positive lymph nodes, then do you want to radiate or do further clearance. And then the Amaros trial had a 10-year follow-up. And the most recent update came a couple of last year or the year before, actually. I think year before, 2018. And the update, 10-year follow-up, it is actually safe. That auxiliary radiotherapy, even in the case of positive nodes, axillary sentinel nodes, they are positive, auxiliary radiotherapy is equivalent to that of clearance. And in fact, patients who are in the auxiliary radiotherapy arm did better in terms of, obviously, because no lymphedema, no shoulder pain, no various side effects that are associated with axillary clearance. So Amaros, so the original.
Santosh is here.
Yeah.
Good evening, sir.
Good evening. Keenly listening to Selvi's voice, which I hear after time.
Thank you, sir.
Yeah, nothing. I just wanted to plan what the next level of my talk is. So
Yes.
I think she covered most of it. So I don't know what is left over for me. Let me just
Your approach is totally
surgical, sir. Surgical. I did most of it as imaging.
Well, okay. I'll then do something like video on something. Let me just see.
Yes, sir.
Yeah.
Sure,
Or I will talk about some reconstruction.
Yes, sir. Your tram flaps. Yes, sir. LD and tram.
LD and tram.
Yes, sir.
Okay. I think so.
On that note, I'll end this meeting and we have to go to the surgical audit meeting next. Thank you so much, Dr. Selvi. Thanks, everyone.
Thank you.
Thank you again.
Madam, thank you very much. Excellent talk.